Um, My Lady, on behalf of Covid Bereaved Families for Justice UK, I make the following submissions in closing in Module 6. The inquiry has heard across the last 18 days of evidence that before the pandemic, the social care sector was poorly understood, poorly funded, poorly represented within and poorly engaged by government. This was nothing new to those working in or caring for people in the sector. Its fragility was well known. But what the inquiry has uncovered is that not only is the situation no better than at the start of the pandemic, but in fact, it is worse. My Lady, reform will not wait for another winter. Baroness Casey's commission will not complete phase 1 of its work until 2026, but work on reform is long overdue and needs to start now. The inquiry must engage with and make recommendations on key structural issues underpinning the failures of government to throw a protective ring around the care sector, those who were and continue to be the most vulnerable to the impact of a pandemic. The focus in your report, My Lady, must not be on rhetoric but on recommendations. So to this end, I'll use my time in addressing you to identify key recommendations that the bereaved families that I represent are clear must be made and must be implemented to ensure that the adult social care sector, a vital pillar of our communities, our families, is both robust and able to safely and compassionately provide the care that people need, even in the next pandemic. So my first area of recommendations is on the issue of parity. The first problem is in conceptualising health and social care as separate needs for any given person. For those with care needs, there is no optimum health without adequate social care. There have long been seen as separate and competing service interests within government. Social care should not be the Cinderella service or poor relative to health services. It needs to be recognised as one system for supporting people holistically with their needs. As Professor Rayner said, there is a need to recognise the importance and expertise of social care as equal partners to healthcare providers. This lack of parity continues to manifest itself through insufficient resources, insufficient wages, and insufficient IPC measures. The position is even worse for domiciliary care providers and unpaid carers, and the tireless work that they do still barely receives a mention in government policy considerations. This lack of parity is exemplified by two important pandemic examples on the evidence before the inquiry. First, it is clear from Helen Whately's evidence that the March 2020 policy of discharging untested patients to care homes was an example of the needs of the NHS taking precedence over social care. The leaders in the NHS England were focused on what they needed to do to, quote, protect the NHS. Mrs. Whately didn't see them being concerned for what that would mean for social care. The discharge of untested patients from hospitals into care homes without adequate isolation facilities must never happen again. Whether discharge was the dominant route is a distraction. It was a route and it cost lives. Mrs. Whately rejected the certainty of the UK government position on the impact of the policy, which, as the inquiry has established, is undermined by the lack of testing in the key period that the policy operated within. The second example is the inadequate provision of PPE to care workers across the sector. Responses to the LGA survey prepared for the inquiry suggest that 44% of local authorities in England experience PPE being delivered to the NHS very or fairly often in the first 6 months of the pandemic. Christina McInerney from the TUC gave the examples of the lack of availability of PPE and guidance for domiciliary care workers, in contrast to the escalations in availability and advice to healthcare workers, many of whom would be visiting the same individuals, but with better IPC than their care counterpart. Reverend Charlotte Hudd spoke of the stark realisation that she had when she realised that funeral directors were coming into the nursing homes where she worked, suited and booted, in hazmat suits to protect them from her. But of course, the two examples, My Lady, are also connected. Discharging people from hospitals before testing was widespread into locations where it was known that there was inadequate PPE. Then that only compounded an entirely foreseeable risk of infection within those settings. My Lady, then to the future and recommendations on parity. The pandemic was a sliding doors moment, where those at the heart of government should have appreciated that social care needs and gripped the resources from the centre. As Caroline Abrahams from Age UK set out, there are 3 things that the inquiry should now recommend as a matter of urgency. First, there is a need for a genuine national care service in each of the 4 nations and jurisdictions with more national infrastructure to support it. The current UK government has committed to a national care service, and the inquiry should state its unequivocal support for this policy commitment and the urgency of it. Second, there needs to be more recognition of the rights of older people and the rights of their carers to be real partners in their care. Third, there must be more structures within government to represent the rights of people with care needs. Helen Whately said that she often would be the only person at a high-level meeting with any input from social care. She also highlighted the need for the UK HSA, the NHS and the DHSC to think about the health of the whole population, including those with care needs. We would add to those recommendations the introduction of a real carer's wage and would emphasise that matters of resourcing are not outside the inquiry's terms of reference. As Miss Carey, King's Counsel, said to Miss Killian on Monday, my lady, you are under no illusions about the underfunding and the fragility of the adult social care sector. And whilst it might be a matter for the executive to determine the allocation of resources, the evidence of the impact of under-resourcing and disparities in resources and the fragility it creates is an entirely proper matter for the inquiry to make findings upon and indicate the areas in which additional infrastructure and resources are urgently required. Without recommendations focused on greater resourcing and increasing capacity, no number of policies or guidance will address the core weaknesses. As Professor Barclay told you this morning, the way to make sure something really happens is to say, right, we're going to resource it. My lady, I then turn to my second area of recommendations, the issue of preparedness. You may recall that in Module 1, Covid Bereaved Families for Justice UK made recommendations that legal duty should be placed on central government to ensure that up-to-date national planning, guidance, information sharing, oversight and assurance exist to prepare for the next inevitable pandemic. Helen Whately correctly identified that for robust planning, there needs to be multiple plans, the care provider level, the local authority level, and a national level. But here there wasn't a national plan for social care, and the social care minister wasn't able to obtain the entirely inadequate local authority plan until March 2020. Cathy Williams told the inquiry that care providers need to have contingency plans according to regulations, but not pandemic plans. Joanna Killian confirmed that local authorities had to have pandemic flu plans, but that was the wrong plan for the pandemic that did in fact strike. It seems that local authorities in England are awaiting the recommendations from the exercise Pegasus in autumn 2025 to inform their work going forward. My lady, you asked Miss Killian what's in place for the recommendations of that exercise to be acted on, noting that key recommendations from exercise Cygnus weren't. The answer you received was vague and imprecise, but your recommendations can make clear that there should be a responsibility on both local authorities and care providers to have those pandemic plans in place, with a clear framework to ensure minimum standards and adequate central oversight. I now turn to my third area of recommendations, the issue around the lack of proper data and oversight. All the witnesses in this module, my lady, agree that there is an urgent need for better data infrastructure within adult social care. So 4 clear and obvious recommendations emerge. First, the need for a national register of care workers within each of the 4 nations. Second, more availability of data on the number of people who draw on care and support and those who care for them, to ensure better provision and access to essential pandemic response services such as vaccines, such as PPE. Third, the seamless linkage of social care and NHS data. And fourth, and better mortality data to identify who, when and why people die whilst receiving care. But data alone is nothing without on-the-ground intelligence and oversight. The inquiries also heard of a lack of accountability and transparency within government at key moments in the pandemic response, what Caroline Abrahams called the circling of the wagons, thereby further excluding those advocating on behalf of the sector. Of the greatest concern must be the lack of oversight of the sector. The CQC in non-pandemic times provides a supportive rather than directive role, and during the pandemic withdrew its inspectors, going AWOL, as Nadra Ahmed from the National Care Association put it. During a pandemic, there must be more scrutiny, not less, particularly behind closed doors. Both routine and emergency inspections must continue during a pandemic, not only to monitor whether effective IPCs, such as isolation and PPE, are in place, but to protect vulnerable people from neglect at a time when access and oversight by family and friends may be limited. Care Rights UK called this a line that should not be crossed. Moving then, my lady, to my fourth and final area of recommendations around a people-centred approach to care. The impact of the pandemic on those receiving social care was both devastating and disproportionate. 27,000 people died in care homes in the first wave, hence Alistair Donaldson's categorisation of it as a generational slaughter. There can be no doubt that the pandemic had a disproportionate effect on people in receipt of care. Professor Banerjee highlighted that those living with dementia suffered the highest level of mortality. This was entirely foreseeable, given that so many people living with dementia will be older in age and have complex comorbidities. But each of the 27,000 is a human being that was loved, and my lady, I know you cannot fail to have been moved by the evidence that's been heard in this module from those who lost their loved ones. May I remind you of the many and varied accounts from the Covid Bereaved Families for Justice UK and friends within the written statement of Jean Adamson. But what all of those harrowing stories highlight is the need for those at the centre to properly understand the nature and significance of compassionate, holistic and people-centred care. People in social care are people, not numbers or statistics or things to be moved around. The first example from the pandemic of the need for people-centred care is the restrictions imposed on visiting. My lady, I know from your questions of the witnesses that you are focused on the competing risks involved in creating guidance and visiting and the importance of balancing the need to reduce the risk of infection against the need for people receiving care to receive those visits from their family and friends. But your recommendations must reflect the recognition that visiting is more than just cups of tea. They are essential to the mental and physical well-being of those receiving care. Family and friends are often the ears, eyes, voices and memory for the people that they care for. Susan Gregson's story illustrates the distress and acute social isolation felt by people living with dementia. Susan moved into a nursing home in August 2020, and in that October, visits were stopped. Due to her dementia, Susan was unable to use the phone or Skype without considerable support. Her daughter Nicola describes the agony of those phone calls in the CBFFJ witness statement. When the care provider thought that Susan was at the end of her life, her family was allowed to visit, but when she rallied, those visits were once again stopped, a decision that will haunt Nicola forever. Not all care homes were even able or willing to facilitate electronic communications. Larry Byrne tells the inquiry that when his dad, Lawrence Byrne Sr., became unwell, the care home staff would not let Larry speak to him and was told that his father had been admitted to hospital by email. The right to visit is central to the well-being of those in receipt of care, especially during a pandemic, and the inquiry should be categorical in its support for essential care supporters being part of the care team in a future pandemic. Through the introduction of Gloria's Law, which Jane Weir-Viboska told you about in her evidence at the start of these hearings. A second example of the need to deliver people-centred care is the use and abuse of DNA CPRs. Many CBFFJ families have provided evidence about DNA CPR notices being put in place for their loved ones without their knowledge or consent. It is clear from the evidence of Helena Herkelotz and Professor Rayner that these were not isolated incidents. Professor Rayner was clear that blanket DNA CPRs did happen, and that there were people and families receiving letters and calls from clinicians informing them that they could be subject to the ceiling of care, messages that no one should ever receive. Professor Barclay made no apology this morning for using the word shocking. It is yet further evidence, if it were needed, that there was a set of, as Professor Banerjee put it, a set of potential biases that entered into clinical decision-making and a generation of health and policy and delivery based on negative attitudes towards older people. Those who receive those letters still don't know how high up those decisions went to CCG level or above. But it's also another stark example of the capacity of the NHS taking precedence over the needs and lives of those receiving social care. As we know from Linda Dinsdale's evidence this afternoon, and from Cameron Malik, and from Professors Hatton and Hastings, it wasn't just older people. It was people living with disabilities and receipt of care who were refused access to intensive care units or ventilators. The inquiry should not only be clear about the existence of blanket DNA CPRs, but also be clear in its recommendation that they can never be appropriate to propose or even tacitly permit. My lady, in conclusion, the pandemic exposed the fragility of the sector, and you now have before you the detailed and harrowing evidence and reflections of where the cracks are and the recommendations of the urgent reform that is needed. My lady, your findings and recommendations can inform and support the work of the Casey Review, but should not wait. The COVID bereaved families ask you not just to bear witness, but to be bold and to recommend the changes that are so desperately now needed.